Um, I'm going to talk about cardio-oncology, and I'll give you a little background. When we started our program, it was probably been about 12 years ago, we were seeing patients that had cancer, and they were being treated for their cancer, predominantly things like lymphoma, that sort of thing, and they were using drugs called anthracyclines. And it had been observed that drugs like that cause cardiac dysfunction. But the statistics didn't show that it affected a lot of people, according to the oncologists, but it became clear that they weren't really measuring their function. And even if they had mild dysfunction, they didn't think it was important. And it turns out it was very important. And so we developed a collaboration with oncology. We found that they didn't want to manage people with cardiac dysfunction. They didn't want to manage high blood pressure, not a criticism, but that wasn't what their training was. And so we formed a collaboration. And just to give you some background on that, it's evolved and been very, very important because I'm sure you know that there's been an explosion of drugs for cancer now and have a multitude of effects on the heart and certainly other systems. And I'm going to talk about that a little bit. So I just want to give you some background on this. And it's really a model. I mean, we all collaborate with our colleagues in other fields, but this has been a true organized collaboration, and I think is very valuable to patients because they didn't know that cancer had such a stigma, but they didn't know that it could affect other organ systems. And even if they were cured, to find out they had cardiac failure or something else was very important. So I'm just going to go through those and leave some time at the end for questions, okay? So I have no conflicts. So some background: cardiovascular disease and cancer are the two top categories that lead to lack of survival for both cancer and heart patients. You know, again, it gives you some statistics about the baby boomers, but the other fact is that with childhood cancer, probably 85% of children that are treated for cancer, whether it be leukemia or lymphoma or whatever they have, they will survive. The problem is that later on, they're at risk for second tumors, and they're also at risk for cardiac events. So many times their survival is a function of their cardiac status rather than their cancer, which was supposedly cured, and it probably was, but they'll develop other cancers. And again, if they're in their 50s or whatever, then they have risk of cardiovascular disease intrinsically, but also due to the cancer therapy. So, you know, cancer treatment has shifted to targeted therapies. There have been more than 30 agents that have come onto the market. And if you look at a graph that shows these agents, it's astounding. It's like someone threw paint at a board, and the new drugs are all over the place. And you see them on television. Now they're advertising on television. So it's been very dramatic that there's been an explosion of these drugs. And our goal, and this is very important, our goal has evolved to the point where if you're treating the patient who has cardiotoxicity, we do not want to stop their cancer therapy. The initial reaction of the oncologist, well, they have this, we can't treat them because they're going to get heart failure. But we have drugs and we have techniques to treat these people. And so our goal is really not to give up on the therapy unless there's some special circumstance, which is very important. At that time, and even now, it's evolving, but there were limited controlled trials on the prevention of cardiotoxicity. And treatment now is based on prevention, early detection, and prevention of progression of heart failure. In particular, there are other diseases that we see, but our goal is to try to anticipate it. And we like to see, if patients are going to be initiated on therapy, we like to see them in advance and screen them for cardiovascular disease. It's like having surgery to make sure they don't have cardiac dysfunction to begin with. There are people that have longstanding hypertension that's not well controlled, et cetera, or they may have cardiac dysfunction and not know about it because it's early in their progress. And I'm going to give you sort of an overview of the structure of a typical clinic. And a lot of it depends on where it's being held and what institution, but these are some basic tenets that and shows you the teams that we need, and also the collaboration. The collaboration is extended to all aspects of cardiology and et cetera. So obviously you need a champion. I hesitate to use that word, but you need a medical director or someone who's in charge of this. Pharmacists have become so valuable and so necessary for the team, again, because of not only the cancer drugs that they're using, but also the cardiac drugs and their interactions. I mean, I think you're going to need an AI computer to figure this all out in the end. We have nurse practitioners that are involved, physician assistants, and again, it's a multidisciplinary team. The outreach programs that are available for cancer patients and cardiovascular disease include consultations with radiation. Patients are getting radiation for things like breast cancer, lymphoma, et cetera, and they have tremendous effects on the heart, which may be later on in their course, but still are a problem. Surgical evaluation, patients are going for extensive surgery or non-extensive surgery, and they have atrial fibrillation or they have cardiac dysfunction. Question is, can they have the surgery? So you have to assess their risk. We're now seeing more, as I said, more children that have graduated to adulthood. They didn't have, unless they went to St. Jude or one of those hospitals, they didn't have follow-up. It was turned over to the primary care physicians. So who are really not familiar with this, and that's part of the education, is to educate the primary care physicians that someone still needs to be followed for complications of their treatment, even though they're asymptomatic. And now the imaging aspects of this have become very important. And you can see the downstream factors that occur. Patients need echocardiogram. The echo has probably been the foundation of a lot of our follow-up. But now with the drugs that can affect the electrical system, atrial fibrillation, QT intervals were mentioned before in the previous lecture. So we need consultation with our colleagues in electrophysiology, because these people may need procedures or may need management of antiarrhythmic drugs which can interfere or affect the cancer drugs. CT, particularly CTA now. CTA is evolving where a patient can have a routine CAT scan of the heart and be able to visualize the coronary arteries. And now, not only visualization, but we can measure flow. A lot of our interventionalists that are here today are probably jealous of this because they have to do that in the cath lab, but that's where it started. I mean, that's how flow reserve was begun, but now we can do that with a CT scan. So if someone's being evaluated for a surgical procedure, this has become very important because it not only gives you anatomy, but it gives you physiology as well. And again, it's essentially non-invasive, and the only risk is the contrast if someone's allergic to it or if they have kidney disease, but very helpful. We have a survivorship program. I mentioned that the number of children that, it doesn't necessarily children, but people that have survived their cancer, again, they're sort of told you're cured, but the definition of cure is very interesting because it doesn't ever mean that they may be free of their disease now, but there's chances of recurrence or development of other tumors, et cetera. So they need people to follow them that are educated in the survivor aspects of this. And particularly for us, it's an assessment of risk factors. So if someone's 45 years old, they've survived leukemia, but they're a smoker, or they have diabetes, or they drink a lot of alcohol and don't exercise, all the things we talked about that, they need to be risk stratified and have interventions to try to change those habits so that you can improve their survival. Also, physical therapy and rehab are important. So you can see the depth of the people that we need to work with for these patients. This is just a summary of what we're doing, and we've moved into the field. First, when it first started, we were treating patients who had the effects of cancer therapy. Now we're looking at prevention. If we see the patient in advance, sometimes we can talk to the oncologist and maybe lower doses of the drugs can be used, or the infusion times can change. So we collaborate with them on how these drugs are administered. And again, they may be high risk for cardiovascular disease independent of their cancer. For example, in breast cancer, previously the average age that women were getting breast cancer was in their 50s and 60s. Well, they had as cardiovascular risk that portended their mortality more than the cancer did. So we needed to assess those people and perform risk stratification and sometimes treat them in advance if they were very high risk for cardiac dysfunction or whatever complication, particularly radiation. If you had a left-sided tumor in the breast, they were getting direct radiation, which can affect the heart. It was primarily the coronary arteries, but we were seeing pericarditis, we were seeing valvular insufficiency, and these were changes that occurred later on in life. So by the time we saw them, they had had their therapy when they were 40 or 45, and now they were 60, and their lipids were up, and they had had radiation exposure. So again, just an example of how this collaboration can work. So when we identify the events or the factors that are involved for these patients, we know now many of the toxicities in the traditional drugs, but because of the explosion of cancer therapy, we can only, it's a guess in a lot of ways. You have to anticipate it. If it's a tyrosine kinase inhibitor, which normally causes hypertension, that may lead you down a road, but there may be characteristics that we don't know about yet. Cancer drugs are released much earlier than cardiac drugs. They're released with smaller numbers of patients. So we're kind of asked to evaluate things based on their history. And the other thing, the radiation therapies have changed in terms of their focus. Again, if someone had lymphoma, they had mantle radiation. They had their whole chest irradiated. It can affect other structures. But now we can be very focused to try to keep the cardiac structures out of the field, particularly the coronary arteries. But we see pericarditis. Patients can develop what they call a hostile chest. So if they needed bypass surgery, they have a lot of scar tissue that precludes them from having that. So again, radiation therapy has evolved to the point where it's much more focused and much safer for the patients later on. And now there are a couple of things I'm going to talk about a little more. And you've probably heard about this, but there's a field that's evolving related to immune therapy. You've heard of these checkpoint inhibitors. Again, you see them on television all the time. But basically, for many years before discoveries were made, it was felt that for some reason our immune system wasn't activated. If you got a bacterial infection, your immune system is activated and you fight the infection. But with certain tumors, the tumor would hide from the lymphocytes or the other aspects of our immune system. And there was a doctor at MD Anderson who discovered that there were certain molecules that were attached to the tumors that allowed them to hide from the immune system. And he designed therapy to remove that, so then the tumor was recognized by the lymphocyte or the whatever leukocyte was available. And now we have these immune checkpoint inhibitors, and they're incredible. And they are prolonging life in many patients we'd never even heard of this therapy. For example, Jimmy Carter, still alive now. He had metastatic melanoma, but treated with immune therapy. He's lived years longer than he ever would have without that. So you'll see more of this. But with any therapy, there's complications. And with the immune therapy, we see inflammatory responses. And it's not limited to the heart. The things that we see is myocarditis and pericarditis mostly, but they can have thyroiditis and they can have inflammation of any system. So again, being aware of this, sometimes reducing the dose initially, monitoring these patients very carefully for heart attacks or myocarditis becomes very important, and especially with imaging, because if someone presents with chest pain after they've had a treatment with Keytruda or some of the things you've heard about, you have a differential you have to follow because the incidence may be relatively low statistically, but they die, and they die very quickly. So we reported this about 5 years ago. We saw a patient who had coronary disease, had chest pain after immune therapy, and then started having ventricular tachycardia. And the issue was, did he have progression of his heart disease or did he have myocarditis? And it turns out that he had myocarditis, and the only treatment we had at that time were steroids. So my point is that you'll see a lot about the immune therapy and stem cell transplants and things like that that are being used that have implications for the heart. I'm not going to go through the whole list, but it gives you an idea of some of the classical problems that can occur as a result of oncologic treatment. And it varies between hypertension. I talked about heart failure. It affects the QT interval. And this becomes very important for a lot of reasons because of the arrhythmic effect, but it also is important because these people that are getting standard chemotherapy are getting antiemetics and other drugs for their side effects of their cancer treatment, and they prolong the QT interval. So they're subject to arrhythmias such as ventricular tachycardia, et cetera. So it's a balance, and you have to find other drugs that can be used for either of these things because those are life-threatening problems. So our electrophysiology friends are helping us, and our pharmacists are helping us find drugs that can have the effect on the nausea, for example, but don't affect the heart, don't affect the QT. We see acute coronary syndromes. Obviously, platelets become an issue. Patients with myeloma can develop a very high, and pancreatic cancer, a very high risk of pulmonary embolism and peripheral vascular disease. As I mentioned, pericardial disease. And then there's another new area, which I won't dwell on, but you'll hear about. It's called CHIP. It's clonal hematopoiesis of indeterminate potential. And what that is, it's fascinating. There are clones of cells that have mutations, but they're not genetic mutations, they're somatic mutations. So there are these clones of cells that exist in many people, and they don't even know about them. But at age 60 or above, later on in life, these cells can transform. And they can transform into leukemias, lymphomas, things like that. But they also can transform, and they put the patient at risk for cardiovascular events, mostly strokes and heart attacks, things like that. So we've actually formed chip clinics where we evaluate people for the most common thing we see is myeloproliferative disorders, polycythemia vera is very common. And we're seeing those patients to risk stratify them while they're receiving their treatment. So I think you'll see more about that because the risk of a thrombotic event is greater than their risk of transformation to leukemia or lymphoma. But I think you'll see more. This just shows some of them. I mentioned the childhood cancer issues, but you can see that the rates of cancer and the rates of cardiovascular disease occurs after the therapy and usually in their 30s. So again, you've had a child that's had therapy to tell them that you don't want to scare them, but the lifestyle issues can make a difference on how they present in terms of either recurrence of their disease, recurrence of other tumors, or cardiovascular events. Same sort of thing. You can see the curves in the blue go way up since they received their initial therapy. And a lot of these were done with anthracyclines as well, but just the disease doesn't stop. I'm going to move on here a little bit. We've evolved to the point where, as I said before, we're treating patients who already have manifestations of cardiotoxicity, but there's certainly a need for cardioprotective effects. So you're taking heterogeneous populations and then translating that into protective therapy. So now we have things that we could, if someone's high risk, we can give them to protect them from some of the complications of their disease. So just a little, the cardiologists certainly are aware of all the risk factors for heart failure, but there's as was mentioned previously, there's such an interplay between systems and there's a doctor in the Netherlands who's shown that if you have heart failure for any reason, you have a higher risk of cancer, even if you weren't diagnosed with of developing cancer, and vice versa. If you have cancer, you're at higher risk for developing heart failure. And we're learning a lot about the physiology of this. There's a lot of signals that go between the heart and the immune system. So it's very interesting, the interaction, and shows the need for collaboration. But you can see some of the things that occur for heart failure. I'm going to move on a little bit. One other concept early on with anthracycline, which we're still using, I mean, it's still a drug that we're using. It was thought that it was kind of an all or none phenomenon, that if your dose that you're receiving was 500 or greater milligrams per meter squared, then you had a high risk of cardiotoxicity. But it's not all or none. You can get cardiotoxicity after one dose, so that the oncologists now know that these people need screening and protection, because as the dose goes up, obviously they're at higher risk. And in their protocols, they're using lower doses, but it's still very common obviously in lymphomas and also in breast cancer. So the women have to know about that, and it leads to more preventative techniques and actually lower doses of the anthracycline that can achieve therapeutic efficacy without hurting the heart. I mentioned QT interval. In the drugs that we know, the QT need a baseline QT interval. It may be long for familial reasons or others, so you need to know what the pre-therapy relationship is, and then as they receive their therapy, to monitor it so that you can identify whether they need an intervention. And I've just listed, again, I said these are just some of the drugs that have been used, but again, shows you some of the statistics about the side effects that they cause. So it's not trivial, and again, it's how it's reported and monitored. If the oncologist thought it wasn't very important, if you look at the original studies, these SEER trials, they were underestimating the incidence of these problems. So these are just some of the drugs that we use now. And again, these are targeted therapies. We're becoming more precise, or the oncologists are, in terms of the systems that are affected, to try to reduce some of the clinical side effects, particularly the cardiovascular aspects. I'm just going to move on here a little bit. The other thing that's interesting, there's some data that patients with hypertension and cancer that are treated with certain drugs, that if they're treated with beta blockers early on, that can prolong their life. And the mechanisms are not really known. But again, if you have someone who has cancer and has hypertension, the beta blocker can be kind of the foundation of your therapy for those reasons. So a lot of research is being advanced now to see why this occurs. There's a doctor that I knew who was looking at prostate cancer, and he found that if the patients were on, or if the animals were on beta blockers, they had less metastatic disease. So the physiology is really becoming very fascinating. I'm going to just go on a little bit here. So this is the other thing we're seeing. We see tumors of the heart are rare in terms of the cancer picture, but people do get tumors of the heart, and they can be in situ, primary tumors of the heart, or they can be due to metastatic disease. Melanoma is one disease where there's a lot of metastasis to the heart. And I don't know if you can see, I don't know if I can point it out, on the left upper echocardiogram, you see the left ventricle, there's no contraction, but there's a mass in between the right atrium and the right ventricle. And they usually go to the right side of the heart, but they can go to both sides. And they're hard to detect unless they obstruct the valve or they have a new murmur, things like that. So the point is, keep in mind that some of these diseases can go to the heart, and we don't know why. I mean, you think about it, why would a melanoma in the foot have metastatic disease to the heart? So there's some signaling that's going on. And I actually learned years ago that there are melanocytes in the heart. Now, why would you need that? You don't need a suntan of your heart. So again, the physiology becomes very, very interesting. And as a result of this, sometimes people can get atrial myxomas, they can get other masses in their heart that are not cancer. So again, for the interventionalists, these things, they may need biopsy, they need more attention. Sometimes they have to have heart surgery to identify what the tumor is, but usually with biopsy, we can get tissue for them and be able to see what can be done about it. There's a doctor at Methodist Hospital in Houston. He's got the largest series of surgical procedures for disease of the heart, intrinsic disease or metastatic disease. He actually does he does a surgical procedure where he takes the heart out and puts it on the table, puts the patient on the heart-lung machine, and he removes the tumor while the heart is out and then replaces it. He's got the biggest series in the country. So, these are rare things, and there's not a lot of people that can do this, but just you can see the implications of this for other specialties. This is just an MRI. As I said, there are multiple imaging techniques now. Echocardiography has been our foundation for this. MRI has been very important. One of our doctors is here, is in Santa Fe now, who I knew when I was in practice in Wisconsin, but is really an expert in different types of imaging. So some of it becomes a choice of what type of image you want, but the MRI has become a foundation for looking at anatomy, looking at for inflammation and things like that. It's been very helpful. The last thing I want to talk about, the other field that has grown with respect to this, and it's part of it is because of cardiology and because of oncology, is the genetics. When you see patients now, their therapy in many cases is designed based on the genetics that they have. There are certain lung cancers that have certain genetic profiles, breast cancer, et cetera, and it allows you to predict what they'll respond to. So their therapy has become very specific, and a lot of these new genetic therapies have less toxicity, so they're not experiencing the traditional nausea and vomiting and weight loss, et cetera. They have complications, but you'll see everybody's going to get genetics. Cardiology, we're doing it now. We're doing cardiac genetics for cardiomyopathy. For atrial fibrillation, there are certain types of atrial fibrillation that are genetically based. So again, fields that we all know about, but really are not trained, but require a lot of new education about this. Last thing, these are the potential services that can be offered. Now, each institution, if they have cardio-oncology efforts, it depends on their institution. But as I mentioned before, a lot of involvement of our partners in cardiology. I mentioned interventional electrophysiology. I mean, these people need pacemakers, they need ablations, they need ICDs, again, in appropriate circumstances. There can be clinics that are associated with your heart failure clinics for cardiomyopathy that are related to the cancer. Obviously, pacemakers. Valvular disease, I mentioned with radiation, that becomes important, so you need people that are familiar with this. MRIs, nuclear stress testing, and any other nuclear studies, PET scanning, et cetera. I attend a lot of tumor boards because the people that are evaluating the patient and their subsequent therapy are very interested in what can be done or cannot be done, so they want our input now. There's cancer related to pregnancy. I shouldn't mention this around Luann since she's going to have her baby in a couple of days, but those are very important things. So the last thing I want to say is, I'm sure it's the same here in New Mexico, but we have a shortage of physicians. We have people that are waiting a long time for their cardiac care, and what we try to do, and it's through the relationships we form with the oncologists and with our teams, to try to get people seen, because it's very frightening and they may need a stem cell transplant or some type of therapy, and they don't want to wait 4 months to see somebody. So we're trying as best we can to accommodate those people and provide better service. So it's a fascinating field. It's becoming more organized. We're working on things like a fellowship. There's no fellowship right now. People will go to an institution to study something for a year or so, but trying to organize a fellowship. But it's really an opportunity for people in practice now or whatever they're doing as a very meaningful collaboration. And the patients really appreciate this because they didn't know that things could happen as a result of their cancer therapy. So, all right, that's all I had to present. Any questions? And I'm happy, again, as David said, I'm happy to talk to you afterwards, and I can give you my email or whatever. But if you have questions, I'm happy to talk anytime. We have a question here. I think we need a mic. Oh, I got the
Hi.
mic. We'll get you.
Excellent presentation. I wonder if you could comment on how much you guys use echo strain measurements to follow, because this is, as you know, is a big topic in echocardiography. And thank you.
So your question related to LV strain, is that what you?
LV strain, because you see changes in LV strain before you see changes in the EF.
Yeah, there's a fair amount of data now that the LV strain aspect becomes very important and can predate clinical observation of cardiac dysfunction. The problem with strain initially, and it's getting better, there were multiple companies that made, obviously, the machines, and they all had different programs. So you could have a baseline strain on a patient on a GE machine and then have it later on something else, and you didn't know if it really represented a difference. Now, I think most of the institutions are sticking with one brand or whatever echo machine they're using, and you can get sequential data. But it is important, and it's also important because with echocardiography now, we can understand more about diastolic dysfunction. As you know, independent of cancer, I mean, patients who have cardiomyopathy with preserved ejection fraction, they have heart failure, and so we need measurements of diastolic dysfunction as well. But the answer to your question is it's an important measurement, but you want to make sure it's consistent with the equipment that you're using. Okay. I think you had a question here. Can we get a microphone over here? Can you just repeat that so people can hear you?
I say, and someone who is a cancer survivor of over 10 years does have other comorbidities that could lead to cardiac disease, no known symptoms of any cardiac issues. Would you still recommend for them to be evaluated by a cardiologist?
Yeah, I mean, a lot of it depends on their age and their other risk factors, but I think risk stratification becomes very important because you can detect things early, and the things we do for that are relatively non-invasive and give the patient a lot of information. So the answer is yes.
Thank you.
Thank you for that wonderful presentation. I was just wondering if you could comment about biomarkers, like in clinical situation. Are there certain drugs or clinical risk factors that you look at before you monitor their clinical markers to start preventive therapy, beta blockers, ACE, how you triage them as outpatients?
Yeah, so the question is about the use of biomarkers, and biomarkers are very effective in certain ways, but they have importance, but they're not the only way to follow these people. They're like a component. For example, if you're concerned about cardiomyopathy, you're concerned about volume overload, et cetera, we use BNP or pro-BNP, et cetera, it becomes very helpful, or troponin. In these myocarditis patients or the patients with immune therapy, the troponin can be very important, but it depends on whether you're doing troponin T or troponin I, and there are differences in the results. But I think they're part of the armamentarium for these diseases and very important. I met with some people the other day that specialize. They look at blood volumes. They have a radioactive material now that they use. It's called Daxor. Daxor is the name of the company. I'm not promoting them, but they can measure blood volume. They can measure hematocrit, and you'd be surprised. It gives us more information about their volume status, whether they have polycythemia or not, et cetera. So I think you're going to see the evolution of these markers. But yeah, we use the traditional BNPs and troponins, et cetera. They help, but they're part of the picture, but not the whole answer. So I think you'll see more being used, but again, it's like we went to, in the ER, with high sensitivity troponin. How do you use that now that you're getting more data than you got before? It becomes important. If it's negative, then that's a lot of data, but you have to put it in the perspective, I think. Does that answer your question? Okay. So you're saying, do you do the markers before? Is that what you? Yeah, and that's a great question, because the answer is yes also, because, for example, if someone has a baseline elevated troponin, for example, you want to know why that is before you start something that can cause more problems. Or if they have, again, an echocardiogram to look at their baseline LV function, they've had hypertension for years, maybe their EF is down to start with. So you do QT interval, you want baseline measurements of these things, particularly the biomarkers, because if you get an abnormal value, you don't know if it's related to their therapy or whether they had that in advance. People that have abnormal troponins at baseline are not normal, so there's something going on there. So, okay, thank you.